through a bit of a background on opioids, uses of opioids, the mechanism of action, and then I'll talk about opioid conversions and some rules that will help in doing the calculations as well. At the end, I'm going to talk about the management of common side effects of opioid, including nausea and vomiting and constipation. So a bit of a background. So there are different terms when it comes to opioids. So there's opiates and opioids. Sorry. So opiates is a term that is used to refer to a substance derived from this plant called the opium plant. This plant produces around 3 opioid compounds or substances, including morphine, codeine, and thebaine. Thebaine is the dihydrocodeine, and there's a bit of a long history here. So opioids have been there for a long time. In 1860, it was used to treat soldiers. 40 years later, it was recognized as a treatment for pain. And because people were using it a lot, they were addicted to it. So 14 years later, it was made only available by prescription to limit its recreational use. In terms of types of opioids, there are weak opioids and strong opioids. Examples of weak opioids: codeine, hydrocodone, dihydrocodeine, and tramadol. Examples of strong opioids are morphine, hydromorphone, diamorphine, and oxycodone. And the point that I want to make here is it's important to not just know that there are weak and strong opioids, but also to know the different potencies. There are different strengths. So for example, morphine is 10 times as potent as all weak opioids. So for example, if you want to convert codeine to a morphine, remember this rule: to convert from a weak to a strong, always divide. So if I told you that morphine is 10 times as potent as codeine, this means the codeine dose divided by 10 will give you the equivalent morphine dose. So yeah, morphine is 10 times as potent as all these opioids. Oxycodone is twice as potent as morphine. So again, we can use the same rule to convert from a weak opioid to a strong opioid, always divide. So to convert from morphine to oxycodone, divide by 2, because oxycodone is twice as potent as morphine. I'll touch on more converting factors and more conversions later in the slides. In terms of the uses of opioids, opioids are used to manage different symptoms. One is pain, 2 is breathlessness, and also used in managing cough and substance misuse. In terms of pain, you all know the WHO pain ladder. So you start with step 1, where you use paracetamol. If that doesn't work, you may go further up to NSAIDs. You can also use an adjuvant with it, like steroid or neuropathic agent. If that doesn't work or the pain persists, you go to step 2, where you can offer the patient a weak opioid such as codeine. If weak opioids are not effective, you step up to strong opioids like morphine or oxycodone. However, there are some exceptions to pain management. There are some types of pain where you need to go to step 3 straight away. For example, in patients with visceral pain, such as appendicitis, in patients with bone fractures or myocardial infarction pain, you should use morphine as first line, a strong opioid as first line in those types of pain. And if morphine is not tolerated, then your second line is oxycodone. In terms of breathlessness, patients who experience rest breathlessness, especially in palliative care, they are offered regular morphine doses because morphine causes respiratory depression, and this will improve the breathlessness. Opioids have also been effective in treating cough, and in this context, they are called antitoxicant. So an example of that is oral morph in intractable cough. They use oral morphine for this type of cough where a patient experiences a persistent cough that lasts over 3 weeks and doesn't have an explained cause. Another medication that is used to treat cough is Fulcodine Linctus, which is used mainly for dry cough, and both contain opioids. Uh, in terms of managing opioid misuse, patients who misuse opioids are offered a treatment called opioid substitution treatment. This includes methadone, which acts as a full agonist, and another example is buprenorphine. These opioids found to be effective in managing patients with opioid misuse. I'm pretty sure we covered this in psychiatry in the placement. And there's a good CBL if you go to Vital that explains this point very well. In terms of the mechanism of action, this is poorly understood. However, there are some points that would make it more clear. So, to explain the mechanism of action of opioids, I found this explanation which talks about the pharmacodynamics of opioids. So, when someone takes an opioid, the mechanism of action depends on a number of points. So, one is the type of receptor it binds to. There are there's like more than 500 opioid receptors in the body, and still under research. However, there are common opioid receptors including mu1, mu2, delta receptor, and kappa receptor. And the mechanism of action basically depends on the type of receptor the opioid binds to and whether the opioid is agonist or antagonist. So to give an example to explain this point is morphine. When someone takes oral morphine, morphine binds to mu1, mu2, and kappa receptor. And when it does so, it produces different effects. So when it binds to mu1, it induces the euphoria state, and it also stimulates the supraspinal analgesia, so it gives the pain relief effect. As well as in kappa, it gives you the spinal analgesia effect, the pain relief. However, when it binds to mu2, it gives the physical dependence effect. So basically, what I'm trying to say is the mechanism of action depends on the type of receptor it binds to and whether it's an agonist or antagonist. To explain this point, there are opioids that act as an antagonist, and they are used to treat symptoms like constipation, to treat symptoms like constipation. Like if you give an opioid antagonist, you're basically treating the constipating effect in some conditions without affecting the pain relief properties. But I don't have the name of this drug at the moment. In terms of the metabolism and excretion of opioids, some of the opioids are metabolized in liver, And when they do so, they go through a number of phases. So there's phase 1 and phase 2. In phase 1, this enzyme, the CYP3A4, is responsible for metabolizing fentanyl, oxycodone, tramadol, and also still in phase 1, another enzyme is responsible of the metabolism of codeine and hydrocodone. In phase 2, this process called glucuronidation, where it causes metabolism of hydromorphone, oxymorphone, and morphine. The whole idea of this metabolism in the liver is opioids are lipophilic compounds. The idea is to change this property, to convert the lipophilic opioids to a hydrophilic structure, so they become more water soluble and they can eventually be easily excreted in kidneys through urine. So that's the excretion bit of opioids. Although not all opioids are excreted in urine. In terms of opioid conversions, there are many reasons why we need to convert opioids. One is the oral route is not available. This means, for example, if a patient has mechanical problems, they can't swallow, or they can't physically swallow, or because swallowing is painful, or for example, if they are actively vomiting, so giving them oral opioids is not going to make any difference, is not effective. So in this case, we need to convert the routes, to convert from oral to parenteral route, like subcut, okay? And it needs a specific calculation here. So consider other routes. When you consider other routes, always remember to halve the dose. So this means if someone's oral route is compromised and you decided to give them subcut opioid or IV, always halve the dose. So for example, if someone is on 40 milligram morphine 24 hours and you decided to convert them to subcut morphine, always halve the dose. So if it was 40 in 24 hours, it will be 20 milligram in 24 hours. This is rule 1. Another reason why we should convert opioids is if pain is responding but patient has persistent intolerable side effects. In this case, consider reducing the dose first and try to titrate it slowly, or consider adding an adjuvant analgesic drug before switching. However, if you decided to switch to another opioid, convert to morphine first. This is rule 2. This is called the golden rule. This means that if you want to convert from one opioid to another opioid, always convert to morphine first. Because we know the conversion factor of morphine. I'll give you an example here. Or I'll give you an example later when we do the questions, because I don't want to confuse you. Another indication is considering the renal and liver functions in patients with renal impairment, in patients with kidney failure like CKD or AKI, morphine becomes contraindicated. Morphine must be avoided, and the alternative is oxycodone. Oxycodone is the opioid of choice in CKD or AKI. And when GFR is less than 50 mils per minute, you should switch oxycodone to subcut alfentanil. So in renal impairment, stop morphine, give oxycodone. If GFR becomes less than 50 mils per minute, stop